well, all of them are multiple choice except for the CIC exam has a portion that's, I call it from scratch, but it's fill in the blank, where you look it up in the index, okay? So we've got Facebook going tonight as well, Boyd. That's pretty cool. And we did that last week.
And I'm just waiting for YouTube to start, and it looks like it's going, something's off with YouTube, it seems like tonight. So there we go. Okay, now I see us. Okay, so I think you are good to go, madam.
I will take my little picture over here out of the way. So tonight we're doing the Profi outpatient support call for February 21st, 2017. You have Alicia tonight. Last week was Chandra. We take turns every other week. And that way you can get a feel for both of our teaching styles as well as us covering different topics. Our students are welcome to come to those live. Even if you're a PBC student, you can go to Chandra's night where she does risk adjustment and ICD-10, very applicable, the ICD-10 portion. And she'll be doing the inpatient, the CIC stuff. Excuse me. Tonight we'll be doing all things Profi and outpatient. Let's just get to our next slide. What do you do when you have a question for CCO? Well, you go to our topics request site. You go to the cco.us website. Let me just bring that up while I'm thinking of it. And let's just go ahead. Got that on the other browser here. We'll just bring that up, set it there. So you have a question, you want us to answer it. All you have to do is go to Contact CCO right there. Then look at all of these awesome things that you can ask us right there as topic request. Very easy to do. You click on topic requests, and then you can pick where you want the topic to be answered. If you don't know, don't worry. We can place it in an appropriate place. But if you know that you want Chandra to do it on the Did You Knows, then you're, that's the DYK. Live with Laureen every week. This call with you and I is the Profi outpatient support call where we cover these credentials, okay? And then there's other calls here as well as our Q&A webinar that we did last Thursday, okay? So you would just fill out this topic request, and then if you didn't know where you wanted to go, we will place it for you. Very easy. That's where we get the information for our student support calls as well as all those others, the Q&A webinars. We get some really great topics for that. So if you have a question that you want us to answer, and especially if you're a student, you can also go to the CCO Club and just pop right in there and put the questions out. I did a few of those today, in fact. We are going to jump right into a case. And this case, first, we're going to look at it and decide what it is that we need to abstract from the case. All right. Now, there's a few ways to do this. And so what I did was I made one slide for the case itself. Usually I go and do like an answer sheet that's separate, but I was able to get everything on a slide tonight. So let's just review this real quick. Is there anything that jumps out at you when you're just looking at this? Don't like read it word for word. What is something that should leap off the page for you? And let's see, you guys can make comments, the ones who are not doing the chat, but anybody that's got their mics open, it looks like Jennifer may be the only one. Jennifer, feel free to shout out or tell me anything that pops up off this page real quickly for you. Anything? Okay, Lisa said basal cell carcinoma.
Okay.
Is that what you were going to say, Jennifer?
No, I was going to say excised lesion.
Very good. That's good too. Absolutely. One of the things that always catches my eye when I'm looking at this is numbers. right? So whenever you see something that's centimeters, you know that's the size, and they're probably going to do margins and so on. But look at these numbers. These three names, monocryl, and they call it proline, but for some reason I call it propylene. I don't know why I put the extra P in there. I just do. But it's proline. They is different types of thread that they use to stitch up. Whenever you see different sizes and different types, that tends to mean that it's going to be a layered repair. Okay, and so often what they'll do is they'll understitch and pull the wound together so that it's got more foundation, it's stronger, and then they'll top stitch, you know, and they'll either do a stitch where they kind of, depending on where this is at, like if it's on the face or something, they want to hide that, and they'll do what they will call a plastic surgery stitch, where it's one stitch with tension and it's pulled through, and so that they literally just take one out and it's not got all those little dots, you know, and it doesn't look like a train track, right? But if it's someplace that needs more security, where each individual stitch is holding that together, then again, they don't tend to do that on the face as much, but some places it's moving quite a bit. So if you like on the hand or repair like that. Okay, those are absolutely the things that I wanted to have pop off the page for you. So we're doing a biopsy. We know that. Let's see, Lisa stated closed in layers. I'll try to keep a track of this as well as I'm looking. Hey, Jennifer, since you can see the chat and you're able to do the mic, you let me know if there's something that I need to pop up. You can be my assistant, okay?
Okay.
I would give you a pair of glasses, but all right. So normally when I'm looking at a case to do for testing purposes, I just look at it just like we did, give it the old coding hairy eyeball, see if anything leapt off the page for me, and then I would immediately go to the codes themselves, and I would start narrowing down what codes mean. But since I can't show you those on the same slide here, and we'll do that with some of the others, let's talk about, we've got a basal cell carcinoma, but I think this may be just CPT codes. I can't remember. So basal cell carcinoma of what body part, where it's at, if we're doing ICD-10, that would be pertinent, right? So let's shelf that for a second. And then we know that it states right here, he excised the lesion and the size. For CPT, very important. It's a 2.6 centimeter, and it was drawn down to the subcutaneous fat, okay? And then extensive undermining of the wound, and he closed in layers, you know, just like Lisa said, so it's more complex repair, and or an intermediate repair whenever you're looking at different types of sutures that they're doing, and they're doing the understitching. Let's see, the attention was then directed, okay, so that was of the posterior neck just near the hairline. So posterior neck in the back, posterior is back, on the hairline, so that's going to be right up here. And then the patient had 2 additional places that were on the cheek, and so he looked at those and he did a punch biopsy. If you've never seen a punch biopsy, go do the Dr. Sandra Lee, the Dr. Pimple Popper on YouTube. She does that a lot, and so she does a lot of punches when she's taking out there's some little lipomas, which is just fat, or some cysts sometimes. She'll do the punch biopsy. It really helps you, especially if you're a visual learner, to watch some procedures done. You can do that by going, there's tons of stuff on YouTube. I like Dr. Sandra Lee because she explains things as she goes along, and she uses the terminology that you would use if you were reading a report. And so if I find somebody that does that for educational purposes, I tend to gravitate towards watching theirs. She does great Mohs surgery as well. So the patient tolerated the procedure well with the punch biopsies, and then she just, you know, they put a little top stitch in there. Okay, so that's what we know so far. Let's go ahead and look at the codes that we're going to have to distinguish from. Since that was a little bit of a longer scenario, that's why I put these on the second page. Now, let me tell you how I work through what I would do to narrow these out. Okay, first of all, we know that they did 2 procedures, right? They did one on the back of the neck and they did one on the cheek. So these are 2 distinct procedures. What does that tell you? What type of when you read that there are 2 procedures being done at the same time during the same visit, what should scream in your head that it's going to need? Anything? I'm looking in my little note. And any idea, Jennifer? Oh, Lisa came back. So what would you think of that you would need if anything? Okay, so what this screams to me is modifier. We've got 2 procedures being done, right? He should get paid for the same one. Now, if he's got 2 lesions on the face in the same spot, that's really kind of like one procedure. They add those together, right? One of the guidelines for CPT tells us to do that. But he's got one here and he's got one here posterior on the neck. So that's 2 separate places. This is not both the face. The neck and the face, 2 separate procedures. So that's the first thing they're testing us on. And remember, when they're doing this, they're not trying to be sneaky. They want to know, do we know the guidelines? And the guideline states, if you're removing 2 lesions on the same body part, then you're going to add those together. But if you're removing a lesion here and like on the arm or another body part, that's 2 separate procedures. Okay, so I need to make sure that I have modifiers. What is the modifier for something like that? Well, okay, let's step that back, because if you look at this, every one of them has a modifier 51 and a 59 except for D. D doesn't have a 59. Who knows what modifier 59 is used for? Anybody? You know what modifier 59 is? I don't think I can just put in 59. Let's see. I may have to sign back in. I may have gotten logged out from earlier today. And I have to tell it I want modifiers. There we go. We got modifiers. Distinct procedural service. Let's look at that real quick. Under certain circumstances, it may be necessary to indicate that a procedure or service was distinct or independent from another procedure. Okay? So that's that. Now, our other one was modifier 51, right? What does modifier for 51 tell us? Little delay there. Multiple procedures. So we did multiple procedures. Multiple procedures. And let's see, the additional service may be identified by appending the modifier 51. Okay, good to know. Let me just get rid of some of these extras. Let's go back here. And now, the next thing my eye is gravitating towards is let's narrow our choices down. And usually the first listed code there is the primary reason why the person's being there and what the treatment actually is. So let's look here. We've got a 131, 32, 31, 32 again here. And here we've got a 12042. Well, that seems way off in left field, right? So usually if there's one that's way out in left field, sometimes you can just go ahead and strike. You can think, okay, that's probably not it. But let's go look it up. 12042. See, these are in the same. You know how Lorraine says you're in the right church but the wrong pew? These are the right church most likely because they're both 131s. 131, 131. So these procedures are really close. Chances are it has to do with size. You know, that is separating the 132 and the 131. Okay, but this is a completely different code, and it isn't that they've taken it out. Sometimes they'll go in and they'll put the 11623 in front of the 13132 to see if you know which one goes first, something like that. But they didn't do that here. So 1, 2, 042, let's just rule that out. If that isn't applicable, we can just strike C right off the charts when we get rid of them real quick. 12042. 0. Oh dear. No, I gotta go back and look. My brain doesn't do good at night. 12042. 1 2. Right.
042.
042. Thank you. Thank you. I need that. It's you can still be a coder and have dyslexia, but I flip numbers really bad. All right. So let's see. What are we looking at here? Is this going to be an applicable code? It's a repair code, intermediate, right? We know we got 2 layers, so that would, it's not a simple repair what they did. Wounds of the neck, hand, feet, or external genitalia, and then they give us the size. Now, let's see. I like that they do this imaging to kind of show you. See, the fact is they do these under stitches under, they actually do that to give it structure and make it close together for a couple reasons. One, so that it doesn't come open and you have a dehisce like we talked about in our Q&A webinar the other day. But in addition, you never want to leave a pocket. Ever leave a big pocket or a hole down here, because what's it's going to do? Your body is going to send white blood cells in there to help heal, and then it's more likely to get an infection. But you could end up just having a it gets painful and red, and just because your body is trying to fight off the damage. That's why they put drains in when they do surgery and stuff. You know, when you skin your knee and all that little fluid, that little clear fluid that pops up at the top, that's what it does, it all over your body. And so, you know, you want to keep that tissue together. All right, so now they've got the bat technique on here. Let's turn that out. So the 2 things that should jump out on this code is the area. So we did have something on the neck, and the size. All right, and an intermediate repair. So is that applicable to what we did? Let's see, the size, somebody remember that, 2.6 to 7.5. Now, before you say anything else, I bet you're thinking to yourself, because this is actually another guideline that you guys need to know about. They say, well, wait a minute. He came in to have something excised. Why would you not code that first? There's a guideline that tells you that if the repair is more complex than the removal, all right, it took more work to do the repair than it did to do the removal, then you're going to list the repair first. It's the way it works with CPT. Right? And it's not just on these type of repairs. The more complex the procedure, then it goes first. Right? So make a little note for yourself if some of you are, you know, new and first in the course. That is a basic CPT guideline. If the repair is more complex than the removal, then that goes first. Very good. Okay, so now we've got the size. Let's go look at our size again. Let's see, I should be able to go back. And we had, of the neck, it was 2.6 centimeters. Ding, 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 2.6. This tells us 2.6 to 7.5. And it was an intermediate repair. They did under stitching. Now, what would make it a complex repair? If they had to go in and do some debridement, cut a little bit to make the area more smooth, had to get it, like, not necessarily debridement, but just really get in there and clean quite a bit, you know, and do a lot of understitching, then of course that would be a complex. And it is in your manual. It's all on the same page, and I don't know what page it is, but when you first get to the removals of lesions and stuff, the repairs, it's simple, intermediate, and complex, and then it gives you a definition for each one of those. So this is actually applicable, right? So that could work. So let's not throw that out yet, and let's go back to our choices. Then I'm going to go ahead and go to 13131. See if I can do that. And let's see what that is.
Complex.
Repair complex forehead, cheek, chin, mouth, neck. Okay. And then the size. Well, this should get you right here. So we could say, well, they did the forehead and they did the cheek and they did the neck. That's applicable. But look, the bat technique should make this leap off the page. 2.5 centimeters. So we get to throw that one out. That's not big enough. So that tells us that B is out. Okay, we don't even have to look at that anymore. 13132, which actually with find a code, I can just hit this one more time. Put the back, turn it off. Repair complex, forehead, cheek, chin, mouth, neck. Okay, 2.6 to 7.5. Now, so now we know that our yellow highlight tells us, okay, that first was on the neck and it was 2.6. So that's okay. But so is this a complex or is this an intermediate repair? And let's see here. It tells you complex suturing or torn, crushed, or deeply lacerated tissue. And you notice that it gets down in here past, and they do debridement, layered suturing. We did do layered suturing, but we didn't get into the vessels, and we didn't have to sew any of the vessels or anything. So what do you think? Do you think that that is a good one, or
No.
do you think, okay, so very good. So just with the information of looking up the first code, what we're leaning towards C. Okay, we didn't even look anything else up. We're ruling them out, and we know, look, these codes are the same. We could, now this code is different, you know, and everything, but here we've got looks pretty good. So you know what, I'm going to go to the next slide and let's see what the answer was. Let's just go ahead and give it a, the answer is A. So now let's go look at the other codes. What's the difference between this? 2 was a repair that was complex, okay? And then the 11623, let's look at that. 11623. Excision, malignant, lesion, including margins, scalp, neck, hand, feet. Excise diameter, 2.1 to 3. Okay, that's applicable because they excise the lesion on the neck. So there's one code for that. Got that one covered. There's your neck with the modifier 51. So our next one is 11100. Biopsy of skin, subcutaneous tissue, and/or mucosa membrane, including simple closure unless otherwise listed, single lesion. So he had 2 spots on the face, right, on the cheek, but did he biopsy both of them? He biopsied one, and he just did 1 stitch. So that's applicable, right? Very good. And again, if you don't know, these are great images to take advantage of, and they just, you know, he used a punch biopsy. They could, this is like a shave biopsy. The punch, they literally punch a hole in you. Okay, so that's applicable. Then the 1110. Is that right? I think that's supposed to be 0. Did we get one that has an error in it? Here we go. Biopsy of skin, subcutaneous tissue, and/or simple closure unless otherwise listed, single layer. Okay. Let's look at the rationale. Are you guys surprised? No, I didn't put the rationale on there. So it is true that with this code, the difference was these two, and is it complex or simple? So let's go back and look at it again. Additionally, the patient had 2 additional areas of concern on the cheek, informed consent, blah, blah, blah. That's all fodder. We don't care about that. I excised the lesion, measuring 2.6 centimeters, as drawn down to the subcutaneous fat with extensive undermining of the wound, and I closed in layers using 3 different types of sutures. The wound measured 4.5 centimeters when he got done. So what are your thoughts?
It was complex.
And that is really the extensive undermining, and the fact that he said layered. That's your giveaway. So he used the 5 and 6 propylene underneath, and the monocryl would have been on top. No. I take that back. I did that wrong. Monocryl is the one that dissolves, and so that was underneath. Then he used 5, and then he used 6 to do on the top. And if you go in and you look at some of this, in fact, she just did a biopsy. I shared it on the CCO Club. Dr. Sandra Lee did one where she removed an abscessed cyst, so it had broken down, and she really had to go in there and clean that up and dig around a little bit, and then she cut some more, and then she did, I think, 5 or 6 stitches underneath, and then she did the stitches on top. So that's a good example of what this would have been like, except for it wasn't a lesion, it was actually a cyst. Okay, so would we have gotten it right if we had stopped there? No. So you have to know whether it is complex, and if you look at these, the only other difference between this, that is the only difference between that one and this one, is understanding what is complex and what's not. So make sure that you do your BAT technique around the repairs. Okay, let's go to the next one, because we are having so much fun. Now I've got these on together. Okay, now we're going to jump to a heart procedure. Cabbage. Looking, just let me check real quick to see if there's any notes or anything. Okay. Now we can give it the hairy eyeball as well as look at the codes. And what jumps off at you? First, let's look at the codes first. Okay. What jumps off? What's the first thing that you see that should leap off the page that makes it different? Anybody? It's Christine, modifier 51, right? So there's a modifier 51 on this one, but only A has the modifier 51. Okay, so if this doesn't need a modifier, we can strike that one off. The next thing that I look at to narrow down is that you would look at this second code. You've got 335, you've got 10, 18, 19, and 17. So that right there is going to be able to allow us to rule some things out. But the problem now, just be careful, because some of us, myself, jump to conclusions and go too fast, right? And so this is a good way to narrow it out. So what you need to do when you're testing and you're doing the CPC exam, you need to be writing yourself a note off to the side. So after A, when you look at whatever 10 is, you're going to write whatever that is, and then 18, whatever that is, 19 and 17, so that you've got yourself a little note. You can do this really quickly, okay? But again, going to the first procedure, we have 335, 35, 34, 33, and 35. So what do we want to do? Well, I tend to, for testing purposes, I always take one of the numbers, either the highest number or the lowest number, and either work back or work forward, because they're going to be they're most likely going to be in your same bubble. So I tend to go with the lowest. So I would just look up 33533, and then I can just go to 34 and then 35, and I can see what the difference is in those 3. Now let's do something. I haven't even read the test question yet. I'm going to go ahead and look up 33533. So let's do that real quick. And let's see what we're dealing with. So we got a cabbage using arterial graft, single arterial graft. All right, so if you need the image, again, now you can go in and look at these, and some of these, if you need to make yourself a note in your manual and draw little pictures, you can do that. But okay, so what we're doing is we are doing a graft. Right coronary artery, left coronary artery. A lot of times what they'll do when they do grafting over here, they'll pull it from the mammary vessel and attach it, and over here they'll pull grafts from another part of the body. So let's just X out of that. So we have a graft using arterial grafts to a single arterial graft. So they're taking an artery from one spot and they're just pulling it over and attaching it, usually is what that means. So it's the next code, because if you're looking at this in your manuals, and you should have your manuals open following along. Let's look at the next one. So what's the difference? Here, same thing, using arterial grafts to coronary artery grafts. That's the difference. 1 and 2. So let's look at 5. 5, using 3 arterial grafts. All right. Now we have a distinctive difference between them. Let's go look at what we're dealing with. Now we know A and D mean 3 grafts. So what did we go? Performed a 4-vessel autogenous coronary bypass on a patient who had a previous cabbage 2 years ago. Now, if we were doing ICD-10, that would give us a Z code we could have used, utilizing the savinous vein, radial artery, and the left and right internal mammary arteries. Whew. Okay, so let's paint the picture here. What are they doing? You got your heart. So let's start. Remember I told you on the one picture that they usually take, let's see if we can bring that picture back up. If they do it over here, they'll take the mammary artery and just reconnect it, because it's a big old fat artery. They can just reconnect it right there. Well, they did that, right? They said they took right here and the left and right internal mammary arteries. The radial artery, where does the radial artery go? Where do you think the radial artery comes from? Any ideas?
Your arm.
Right. Why do you think it's from the arm? Because it's your radius and your ulna, right? So that artery that runs up in the arm, they call it the radial artery. And then the savinous vein, though, where is the savinous vein? Does anybody know where the savinous vein is? Savinous vein makes a difference. Let me see if I can just go over here and grab this, because I want you to know. Some people call it saphenous vein. I call it savinous. Oh, I may not be able to even spell this. Hold on. It's too late at night. P-H-E-N. Okay. Savinous vein. Let's just grab this picture right here. See if it comes up clear for us. And if you were listening to Chandra's cardiac lectures for chapter 10 that she did live here not too long ago, you would know that the savinous vein is like the most common vein that is taken from the leg. Okay, it's a nice sturdy vein, and they use it to do grafts right there. Oh, hold on just a second. Let's pause just a moment here and let me fix this real quick, because my son knocked over my green screen. Hold on. Okay, let's see. That work out, Boyd? Yeah, we're good. Okay. And we're back. Sorry. Okay, so this saphenous vein, or saphenous vein, however you want to say it, is, you're going to see that in almost, I don't want to say every cabbage, but it's going to be very common. So what do you got to do? You got to remove a piece of that vein here. That's another CPT code, right? So we're adding to our codes. We know we need to do that because we did right here, saphenous vein from the leg, radial artery from the arm, and left and right internal mammary arteries. So we grafted or pulled over three veins to take care of this. That's 3 of the bypass, and then the saphenous vein. So that's our 4. So we go back to this code. What does it say? 3 coronary artery grafts. Did we do 3 coronary artery grafts?
Yes.
What do you think? Yes, because we did 1 radial and 2 left and right internal mammaries. That's 3. Okay, but we have 1 more, which is saphenous. So we need a code for that, right? So let's go. So now we know we can knock out B and C, right? Because we did more. This was just for 1. That was for 2. This is for 3. So B and C striked off. We can get rid of them. See how we're saving ourselves time? Now that gives us 33510 or 33517. So let's go look at 33510 because that's the smaller code. 335. Let's go see what that one says. Coronary artery bypass, vein only, single coronary venous graft. Okay, so here's another picture that shows us. The heart. Oh, and I think I told you last time that if the apex of the heart is facing this way, you know, off to left and right, you know, it's confusing when you're looking at something. I can't really remember what you're seeing, but when it goes off to this side, that means you're looking at the front of the heart. If it goes, the apex goes off to the other side, then you're looking at the back of the heart. So we're looking, and here is the vein graft. See right here where they put that vein right here? Right there. You can see the little stitches. I don't know if you can see that. Okay. So what does this say? Coronary artery bypass, vein only, single. Okay. Now, what was the other code we wanted to look up? It is a 33517. Now, one thing you can do with this is, which makes it easier because it's like what you're doing. 33517. Can't do it that way because it's actually in a different grouping. So let's go 33517. Bypass using venous graft and arterial grafts. Single graft, a vein graft, lists separately in addition to code for primary procedure. Then the guideline, AMA guideline says use 33517 in conjunction with 33533 through 33536. So 333. Okay. So that when you use, it tells us we can use these 2 codes together. That's a heads up, right? And what's the picture showing us that's different? Using combination of a vein and arterial grafts. They did a vein and arterial graft is what they're telling you. So what does that say to you? Okay, so here we go. Let me go back. Oh, wait, we got lots of conversation. Okay, so Stacy said D, Christy said leg. Let's see, sorry, didn't mean to send that. Yet I agree with Stacy. I was thinking out loud and laughing, and yes. So this tells me, is this saying that D, when you use 33517 when you're using arteries and veins? Does that sound right to you? Let's go ahead and look to 33530. Let's just see what that is. reoperation procedure or valve procedure more than 1 month after the original operation. Now, look at all these guidelines used in conjunction with, let's see what this picture, I always like looking at the pictures. I think it, come on. Reoperation. Okay, is redone after a month has passed. All right, operation is redone after a month has passed. This one says more than 1 month. Well, what did they say? Oh, quarter of a patient who had a previous CABG 2 years ago.
It's more than 1 month.
That's more than 1 month. Very good. And then our last code we're going to look up is 35600. See how this is all painting a picture and telling a story? Harvest of upper extremity artery, 1 segment for coronary artery bypass procedure, and lists separately in addition to primary procedure. It tells you what to use it for. Okay, so I think by this code I told you wrong earlier. They take the radial artery. Remember how I told you they took the venous vein from the leg? They're actually taking this section and going in and redoing it. Unlike going here and reconnecting it here, from here to here, taking a piece, because obviously there's no branches here. The mammary artery does have branches. Okay. Now, what I would urge you to do, so we don't use too much of our time for that tonight, but go look up, and you can do Google Images and do CABGs, and then see the mammary. And what they do is that mammary artery runs across the chest, and how they just grab a piece of it and attach it over there. So so they're actually doing it like they did the vein of the leg. And isn't that what they did? They said usually, and so they did do that. And then the left. Okay. So I think everybody said they liked D. Let's go see what our answer is. It is D. We did not need a modifier of 51 because this is all commonly done together. Okay, now another thing is there are guidelines about taking a venous vein, and you know, and like the repair and all that other stuff like that. That there's bundles and stuff like that in there. That is not what they were testing us on. So we will revisit that another time too. That is going to pop out for you when you do your BAT technique in the cardiology section. All right, so I think I've got a question here. Let me go look. Let me make sure I got them all. And Stacy says, in my notes, besides 33535, it says to use 2 codes if combining with vein bypass. And my notes for 33517 says to use that bubble with artery bypass. So there you go. She's already got her notes in. You're good, Stacy. You're already past that point. Yay. All right. We are moving right along. Here is the rationale. Now, this question was actually taken, oh gosh, did I take this from, I don't remember if I think I might have taken it from our final. I can't remember which one I did, but this is what our rationales look like. So because this is a combo graph, they're telling you the codes 33517 through 33523, that's the bubble that you're working in, must be coded for the venous portion of the graft. And then also the redo is the 33530 is appropriate. And how do you look those up in the index? You're going to go under coronary artery bypass graft, then arterial venous, not just arterial and not just venous, but you do both of them. So there's codes for arterial, there's codes for venous. And it directs you to the 17 through 19, and then also these other codes. And then the arterial bypass, which directs you to the 33533 through 33536. Each of those are little bubbles that you've done with the BAT technique. Okay, and then in the CPT index, you the 35600 is that harvest of the upper extremity. Someone would say, well, how come they how come you didn't do the saphenous vein? If you go look at the codes around the saphenous vein that's so commonly used, they don't use that as a code. It's bundled, I think, is the answer. Okay, so don't overthink it. Just step by step, picture, tell the story of what's being done. And that's how you would take questions that have several codes that you need to look at to determine which is the right answer. Any other questions or for anybody? Okay. We're making really good time tonight. Oh, I got another one. Okay, one of the reasons I picked this one, besides the fact that it's ICD-10 and I just like ICD-10 more than I like CPT, is the fact that it's a cardiac tamponade, and I just love to say tamponade. I love to say cardiac tamponade. Now, if you don't know what a cardiac tamponade is, that is a big scary deal in the ER. So let's go in and look at a cardiac tamponade. There you go. Got here. Here you look. This is a good picture. Cardiac tamponade. So if you didn't know the anatomy of the heart, we actually have like a pleural sac around our heart. You have a pleural sac around your lungs as well. Why? Because it's a membrane that allows it to not get irritated. So it's protecting the heart and it's protecting the lungs. And in between that that pericardial sac and the heart muscle itself, there's fluid or mucus or whatever you want to call it. And so anything that has to move frequently, your lungs, your heart, pump, 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 pump. So it's constantly moving and creating friction. So each one of those organs is in this little sac, your heart, a pericardial sac, and there's a little bit of fluid in there and slimy stuff, mucus, you know, that allows that to slip. So as the heart is going like this and pumping, that sac is keeping that moist and lubricated. Have you ever seen them drill something like metal and they pour water on it? They have to keep it cooled off, you know, because friction produces heat. What does heat do? It damages the tissues. It damages the heart. Well, that's the good thing that it does. The bad thing that can happen is that you can actually get fluid buildup between the heart and the pericardial sac. All right. Now, it's all kind of pressurized. I guess you could think of it that way. So let's say we took a, let me think of something. Think of your heart as in a balloon. Okay. And you fill the balloon up with air and you drop that, let's say we drop an egg, it hasn't been boiled, a fresh egg down into this balloon, and you put air in there and it bounces around and it protects it and everything. And so that egg is okay. But let's say that instead we fill the balloon with water. Okay, and we have a soft boiled egg, and then we fill that up with water, but it's pressurized, and so we keep putting more water in there, but the pericardial sac can only stretch out so far. It's a tiny balloon. What's going to give? Either the heart is going to be squeezed or the pericardial sac is going to rupture, which is not usually likely to happen, but if it does, then you bleed. Okay. Ultimately, what pericardial tamponade is it's pressure that builds up in the heart or around the heart so that it cannot pump efficiently. Okay. And that could be fluid. It could be blood. It could be liquid. It could be infection. This also happens with the lungs. You've heard of people getting pleurisy and it's incredibly painful. That's almost like a drying out of the membrane around the lung. That can happen to the heart as well. But a cardiac tamponade is a squeezing of the of the heart, and so that it can't pump properly. And what will happen when that when they look at you, and this is why when you're looking at reports and they're doing like a cardiology report and they check this, you know, the coronary arteries, and they say they're midline, blah 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 blah, you know, and they got good turgor and all that other good stuff that they're talking about, no brutes and stuff, but they will state that the trachea is midline. Why would they say that? Well, because, you know, is your trachea going to be moving around? You know, it's attached to some pretty sturdy things. The fact is if you have a cardiac tamponade, or you have any type of tamponade in the chest, the trachea will start to deviate. So when you have a trauma patient come in, especially like a car injury or a head-on collision or something, they immediately, one of the things you assess is that the trachea, is it midline? If it's deviating and that person's blood pressure and pulse is not right and they're having trouble breathing, then they've got pressure buildup in the chest, and it could be a cardiac tamponade, and they need to take care of that very quickly. So now we know what we're dealing with. Let's go look at the codes. Wasn't that fun? Oh, Christy says, is that like CHF? No. CHF is a buildup of fluid and the heart fails, but really the tamponade is different. I mean, I guess it could be a tamponade. You could build fluid up there. And I'm sorry, my brain thinks trauma, because that's what my background was, and that's what I enjoy. But congestive heart failure builds up fluid in the entire body, and it backlogs. And so, yes, you could technically have a tamponade situation and stuff where you have cardiac failure because of that fluid building up. But I always think of too with CHF people, they've got lots of, especially your lower extremities, swell really bad. So yeah, that actually could be something that they're starting to have some cardiac tamponade, or those symptoms. So you're right, and I'm thinking, no, we got to have a head-on collision where the steering wheel slams into the chest. But, sorry. Here's another reason for one: a pseudoaneurysm, cardiac tamponade, and left ventricular failure. Is that exciting or what? It's like, you're right. There's so much going on. So let's do what we did before. Let's look at the codes and let's rule some codes out. We look at the first code. We've got I-72.9 in A and D. So we know that in ICD-10, 9 codes usually mean unspecified, right? It's just a kind of a general rule. 3 and 8 are probably going to be where it's happening, right? So out of, let's just look at the diagnosis: a pseudoaneurysm, we have a cardiac tamponade, and we have a left ventricular failure. Okay, so which is going to be worse? Which do you think is going to be most severe? What do you think? Stacy's already saying it's A. Jennifer is too. You guys are getting ahead. You guys are so excited, I can tell. All right, so probably when we have a left ventricular failure. A failure is a big bag deal when you're going with the heart, right? We have a cardiac tamponade and we have the pseudoaneurysm. Okay, so ultimately a pseudoaneurysm is like a false aneurysm, or it's not really it's not that the wall is thinning per se. A pseudoaneurysm, this is probably brought on because of there's so much pressure right there that it's causing an aneurysm. An aneurysm is a bowing of the vessel, right? It's starting to balloon out. It's like a stretch mark in the artery. That's what it is. You know, stretch marks from having babies, you know, how kind of that skin stretches. That's what we got here. Okay, so let's see these codes. The second code's all the same except for the 4, and the same with the 1. So honestly, I would look up this one first because it's the most unique out of the other 2. And so let's look up the I-72.9. We know the 9 is unspecified. Okay, aneurysm of unspecified site. Well, it is a fact that they did not tell us where the aneurysm was, did they? Okay, so unless there's a code for a pseudoaneurysm, then that's not going to do us any good. Okay, so I31.4, let's look at that one. And all these I codes are cardiac codes because think of ischemic heart conditions. Cardiac tamponade, bam, got it, right off. And code first, underlying cause. Why do we have a cardiac tamponade? Because we have a pseudoaneurysm, right? Ding, ding, ding. Okay, let's go back and look. What's our next code? I50.1. Left ventricular failure. Well, you can't get more specific than that. So that tells me that I50.9 is probably a ventricular or a failure that's unspecified. Let's just go double check that. Then we can do that real quick by clicking on this and I50.1 and scroll down to 9. Heart failure unspecified. This is very specified. And so what does that tell us right there? That code, I50.1, tells us that 0.9, all of those others are ruled out. So we didn't even have to look up those other codes because we know it has to be I50.1 because we've got a higher specificity, left ventricular failure. So we have a cardiac, we have an aneurysm, we have a cardiac tamponade, and a left ventricular failure. Is that how you figured that out? Did you guys do it that fast? That way? Okay, let's see. We got some more. Stacy's got AAA and then Jennifer. Okay, so don't worry about that. Jennifer has to go. Don't worry because this is all recorded. Boyd will have it up in, you know, in a few days. It'll be in your student access area and you can go back and see the other great cases that we have to go over tonight. Any questions about that? And we'll see you next time, Jennifer. Lisa said A. Looked up cardiac tamponade first. Very good. Now, okay, let's look at this really quickly from the viewpoint. Let's say we didn't have our answers, right? And which term would you look up first in the index to get the highest specificity? If I was just told to code pseudoaneurysm with a cardiac tamponade and left ventricular failure, which code would I look up first? I would look up left ventricular failure because it's the highest specificity. Now, that doesn't mean I'm going to code it first. That's if I'm going to look up something, I tend to work backwards that way. But if I were to say, okay, out of all of those, and I'm going to not look at the codes in the choices, I'm going to go to the index. Don't do this while you're testing, guys, because you don't have time to do this. But if somebody's saying, oh, I think the code is blah, 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 I'd look up left ventricular failure because it's specified left and it's ventricular. Okay. So you can have left and aortic failure. You can have left ventricular failure, which is more common. And you can have unspecified, which is the 9. Oh, so Lisa said, yeah, that she looked up cardiac tamponade. Cardiac tamponade is pretty specific as well. I would not have tried to look up pseudoaneurysm because there's tons of types of aneurysms and it would have just taken longer in the index. So obviously pseudoaneurysm doesn't have its own code, I guess, or it's saying it doesn't tell you where the aneurysm is, and 9 is the highest specificity. Now let's look at something else really quickly. This popped out at me. So we have I72.9 and 71.9. Let's go look at I71.9 because those two are close. What were we looking at? Oh, wait. Aortic aneurysm of unspecified site without rupture, aneurysm of the aorta. This is all specifically the aorta, right? And we do not say that it is of the aorta. We don't know where the aneurysm is. An aneurysm can be any, the vascular system is vast. So again, that was not a good choice. And I25, that's like a heart attack. I3-4 is also another type of heart condition. So again, the fact that these two are so close, those will be the ones I gravitated first to look at. All right. Any more questions about that? Very good. All right. We're getting a little bit of practice with both. And I think, do I have another one? Oh, I'm just showing A is the correct answer. And the rationale. You look for aneurysm. The subterm pseudoaneurysm is not listed. Therefore, the unspecified code of I-72.9 is correct. Then for the tamponade, you're going to go to tamponade heart, because you could have a tamponade of the lung, refers you to I-31.4. And then in the index, you would look up failure, because that's what happened. We had a failure. Where was the failure at? It was in the ventricular, and higher specificity is of the left, which ends in a 1. The 1 is what indicates that it's left. 2 is probably right, and 3 is probably both, and then it would probably go to maybe 9, unspecified, I'm guessing, or whatever it said. It said unspecified heart failure, right? Okay. Excellent. We got another one. Yay! Went to another body system. Are you ready, guys? So now we're doing ICD-10 again. Mrs. Gray, well, okay, let's do what we did before. Let's look at these codes. Now, these codes are all really pretty close to each other, aren't they? They're all G4 codes, G44 or G43. I personally would look up G43.9 first, because it is an unspecified code or a more generic code, and it's off kilter. So I want to be able to rule that one out quickly. G codes are going to have to do with the brain. How do you remember G codes are used for the brain? I remember in I love to Hercules, how do you say him? The lady who wrote the Agatha Christie novels. She also wrote novels for the guy. He's Belgian. He's not French. He's Belgian, and he's got the little mustache. And he always says this one little phrase he's always saying is the little gray cells. You know, we got to work our little gray cells. Well, because that's literally what they call the brain. The cells in your brain are gray cells. That's what you medically call them. And so you can remember it that way, that anything going on with the brain is going to be little gray cells, or ganglia is in the brain, and ganglia starts with G. So you can, either way. So anything going on with the heart is going to start usually with an I for ischemia, or you can remember I heart you, I heart, you know, I love you. So anyway, I try to do that when with the ICD-10 codes. I used to do it, you know, with the numbers in ICD-9, but it's much easier to do it with the categories with the ICD-10. So I have fun. So our little gray cells will be working now. Let's rule out G43.9. Now, and you'll have a lot of questions that are this simple, you know, this small on the test, the CPC exam. A lot of them will be longer cases with lots and lots of codes, but don't let that fool you, because you could have 5 codes for something as simply stated as what we've got, just like 3 sentences. Right? They could pack a wallop with ICD-10 and CPT codes. Honestly, I personally think the ones that are a page and a half a case, and usually when you open up that book, the first 2 or 3 are really intense, and you got like a 2-page encounter right there, the very first one, you know. Those are actually kind of easier because it's mostly fodder in there. It's stuff we don't care about, sterile technique, blah, blah, blah. You know, we're going to gravitate towards, you know, is it a repair? Was it complex, intermediate, or simple? You know, do they do more than one procedure? You know, those are the things that we're going to, you know, what body part are they working on? You know, that's what jumps out at you. So this sometimes can be more complicated. Since this is short, I regress in what I was going to say. Let's go ahead and read it. Mrs. Gray has been experiencing headaches for a number of months, and after extensive testing, it's determined that she has intractable chronic cluster headaches. This would be coded with code. All right. So Who knows what intractable means? Does anybody know what intractable means? Just out of the blue. Let's see here. I've got people already telling me which one they think it is. Stacy's already given me what G4 3.9 is. Christy says it's B. Christy says no. Intractable chronic cluster headache is B, and that's good to know. So intractable usually means, if I remember right, which we'll look it up, that whatever they're doing to treat it isn't really working. So let's do that, because they use that, but I might have that word confused with another word. Let's look this up real quick. Intractable. I'll spell it wrong. There, I did spell it wrong. Intractable. And definition on images. Yeah, intractable. Okay, my son has intractable epilepsy, meaning it doesn't usually follow. It's hard to control or deal with. There you go. It's difficult or stubborn. So if your spouse is being stubborn, he's intractable or she's intractable. I wouldn't advise you going and saying that unless you want to just make yourself feel better because you know some $10 words. So it's hard to control. So she's having headaches, and them being intractable, if we read the whole case or the whole encounter, it probably would be saying that she's tried this, she's tried Tylenol, she's tried ibuprofen, she's tried, XYZ, and it's nothing is making it better, and stuff. And cluster headaches is a specific type of headache, and chronic, meaning it's going on for a long time. Okay, so intractable is used with epilepsy, it's used with headaches, and it's used with pain, different types of other types of pain. So if you see that word again, it might be one that you want to write down in your notebook that you can go back and reference. Cluster headaches, again, is a specific type, and you can have cluster headaches and then not be chronic, but chronic is a specific type of headaches. So we were already told by, who was it? I think Stacy told us that G 43.9 was a migraine. Now, I don't tell you to memorize codes, but people have lots of migraines, or, migraine's a big deal. Now, and people will have a headache and say, oh, we got a migraine. Well, migraine is a specific type of head pain. And so you don't want to diagnose a headache as a migraine or a migraine as a headache. It has to specifically say that it's a migraine, and there's all different types of migraines when they see auras, etc., etc. I know that because my son, who has epilepsy, the one that knocked over the screen a little while ago, he has epilepsy and autism, and with his epilepsy, he gets migraines, and they're the type of, he also gets headaches, but when he has the migraines, it's no sound, no light, he throws up, he, it doesn't matter if he's got anything in his stomach, and he has to ball up, and he will sleep for like 5 hours. Hopefully, if he goes to sleep, that's a good thing. But sometimes he just has a headache, and he'll walk around and oh, can I have a headache pill? And he actually used to take naproxen for it, but now he takes ibuprofen because the naproxen doesn't work anymore. And so again, there's a difference between a headache and a migraine. Migraines also, again, you can see auras with them. And I had, for the first time in my life the other day, an ocular migraine where you had I didn't know what it was, but I saw like all these crystals, and it was with light shining through them, and it was like, it was jagged and really interesting. And it started out small, and then it went like this, and I thought, oh my gosh, what is that? Was I'm having a stroke or something. It didn't hurt, but it didn't go away, and it lasted for a long time. So I went and looked it up, and it's like, oh, it's an ocular migraine. It's actually quite common, but it could indicate that you're about to have a migraine. So and I didn't. So anyway, again, be very careful when you think headaches is very simple to code, but there's a lot of details around there. So don't Don't get confused or jump to conclusions. So we're ruling out A because G43.9, Stacy let us know that that was a migraine. So we're going to skip that one. And let's go to G44 and let's see if we can go to G44 and look at in, I don't know if we can go G44 in here and just do that. Might have to put more in there. Is it going to let us do it? Okay, G44 is other headache syndromes. Don't let the word syndrome fool you. So now we're looking at what it would look like in your book. We have vascular headache. We have tension type headache, post-traumatic headache, drug-induced, complicated, and other specified headache syndrome. Well, what was our choices? Let's go look. So we have 0, 1, or 2. So what are 0, 1, and 2? 0, cluster headaches and other. So it's 0 because 1 is vascular and 2 is tension. So we're going to go here. And then it tells us cluster headache syndrome unspecified, episodic, chronic, episodic, and this is a different type where it's located in the brain, and chronic. So you can look those words up. But here we go. We have chronic cluster headaches. And is it intractable or not intractable? It's intractable. It's hard to do. G44021. G44021. B is right. You guys are most excelente. One of the old, I know some Spanish. Muy excelente. Muy excelente. All right. So again, real easy to do that. Rule them out real fast. Just open up your manual, go to G4, and you can start at, G43, and G43 is probably here, and G44 is probably right here. It could be on the same page or side by side, and just rule them out real quick. And because you probably, let's see, I don't think we've got the BAT technique and stuff. No, we do have notes and stuff for our students on the ICD-10 manual. Chandra did a brilliant job of putting those together for us. And so there will be notes off to the side if you've done that already. Okay. Any other questions? You know what? I think this might be our last case. So rev up those questions and let me look and see if that's our last case. Okay. G44.021. Very wise choice. Choose wisely, my friend, right? Choose wisely. No questions. Let's talk about anybody that's getting ready to test. Nope, I'm not seeing any questions come through. Okay, so who on the call that's in the call? Anybody getting ready to test? Let's see, we are almost through February. Can you believe it? I can tell you I'm excited because my husband graduates in May, and we find out where he's going to be called to where we're going to be moving in April. Stay tuned. I'm sure we'll be talking about it in the CCO club because I have to move a lot. Then I won't have to move for a long time because we're done with his graduate degree. Christy says, come to Boston. No, I'm not coming to Boston. I might come to visit you and I could do a lecture for you for your local chapter, but I'm not going to live in Boston. No, too cold in Boston. Joanne lives over there, and I think she had snow above your head the other day, she was telling me. So I like the snow, but my husband doesn't, and neither does my #1 son, and I've enjoyed having him around his mama, even though he's almost 30. He's taken the last year or two to stick with us and help us out with some things. So no, don't want to go to the East Coast. Sorry, come visit. It's beautiful out there, guys, but don't want to be living in Boston, but I do love your accents. Do love it. You got beautiful accents. Mississippi's more like it. My mother was born in Jackson. All right. Anybody testing? Let's see. No. Oh, Lisa says, You want Texas because of your grandkids, right? Very wise woman, Lisa, remembers that I have, my oldest daughter lives in Texas, and she's given me 3 grandbabies, and the last one I got to see in July, right after she was born, and then moved back up here. So yeah, Texas would be kind of nice. East Texas, not West Texas. I don't want to do West again. Okay, how many of you have taken practice exams so far? Anybody doing practice exams? We have fabulous practice exams. You know, our Ruth is brilliant at doing these practice exams and writing rationales. Honestly, I don't think I've met anybody that is quite as good as she is. She just gets better every year. And the rationales that you see that we just went over, those are puny compared to the rationales that she writes, right? Her rationales are through the roof and step by step and why things are wrong, you know, in comparison. So nobody's doing a practice exam right now. We give you, with our PBC full course, remember, we give you, you get a midterm, you get a final, you get 3 practice exams. We have the free practice exam on the website. You got 3 practice exams, more coming. They're being vetted now with the free CPC, and then we have an ICD-10 practice exam. And then if you want to just go take the COC practice exam we've got, it's almost the same exam. The payment methodologies and some of the, you know, there's like 20 questions that are different in the real COC. But again, it would still be fine to use it as a practice exam as well. COC and the CPC is right. Christine, you're right. We have the CRC practice exam. I love the CRC. Woohoo! Right? You know that. Okay. So, are you guys in the support hub? Anybody having trouble with the support hub that's on the call? All the students should be in the support hub, actively working in the PBC student support hub, the CCO. We've got them all divided up in different categories. One for the CRC as well. Anybody having trouble with that? Because if you are, you need to reach out to your coach, or you need to send a note into help desk and they will get you right in there. We've been moving some of the stuff around. Great way to ask questions. Go in and find the video from Dr. Sandra Lee that I just posted today in the CCO club of the complex, I would say that was a complex repair that she had to do after she did the abscess, the cyst abscessed. And so it wasn't an IND. You know, I have to think about, it was an incision and drainage. It did abscess. And she did end up doing a repair. Usually they leave those open, but she did a repair. So, you know, I'd have to look into that to see if it's not common to do a repair on those. If something abscesses, they want the infection to be able to drain and let it heal from the inside out. But this was pretty bad and extensive, and it got like roots and went off in several places. So that's an interesting thing that we might have to look into. We code. In fact, I put on there a note, make sure that you code for that. I think maybe I put it in the PBC one. I thought I put it in the CCO club, but maybe I put it in the PBC. Okay. So double check both of them. Is that what you were saying, Stacy, that I put? Are you supposed to be in the club if the PBC club, or is it you should have access to both. The CCO club would be general, quick, mainstream questions. PBC support hub should be, you know, towards the PBC course, or things, you know, specific questions, or, you know, that would be about PBC, ICD, CPT, but the CCO club would be kind of mainstream things. I found this article, or I saw this, or I'm struggling with this, you know, things like that. Yeah. So if you don't have access to both, you need to let the help desk know. They'll get you into everything that you have access to. All right. Everybody should be probably, if you're past chapter 3, 4, and 5, the hardest chapters in the PBC course, you're probably already doing the BAT technique. You're, you know, already into that. So I think most of the people, I kind of know everybody that's on the call. I see the names and everything, kind of know you guys. Some of you are new, but practice exams, when you get to that point, I think Stacy said she was getting ready to start, you want to be getting 85% or better. You may not get it the first time you take one, but then take the next one and then the next one, and by the third one you should be getting 85%. If you're not, go back and pick an, get another exam so that you can do your final, the 3 exams that we give you, and then you've got the free exam, and then you've got other ones to do. And then go buy the AAPC has 3. They're not the same as ours. We've been told that ours are harder than the CPC. So, if you're getting an 85 on our practice exams, you should be able to blow the CPC out of the water. Any other questions about that? If not, I think we need to go ahead and do a wrap up. So I'm going to have to change screens here. Oops, no. Go forth and code, right? Now let me exit this and let's talk about what we want to recap. So what did we talk about first, guys? We coded CPT and ICD. I think I spelled scenarios right. Ha, I did. No red line. Oh, no, it got a red line. There was a delay. It gets late and I have trouble spelling. Okay. We talked about, let me go back and see if I can look, you guys refresh my memory. So we did a lesion removal, repair, complex, right? We did a bypass, 4-way bypass, right? 4-way, arterial, and I spelled arterial wrong, and venous. Let's just put artery and vein. Make it easy on my brain tonight. My little gray cells, they're getting tired. It's been a long day. Bypass, 4-way, artery and vein. What else? You guys are good, man. Then we also did
Cardiac.
which one?
Cardiac temp.
Oh, tamponade. How could I forget cardiac tamponade?
I couldn't remember the last of it.
Oh, tamponade. That's wrong. I think it's an E. E-nod. Tamponade. Oh, there it is. Okay, cardiac tamponade. I'm not going to write pseudoaneurysm, and I'm not going to write heart failure. Although I should, because I will just say aneurysm so I don't have to spell pseudoaneurysm, although I know how to spell pseudo. Let's see if I can spell aneurysm tonight. A-N. You get close. Aneurysm. Left ventricular failure. And very good. And headaches. I want to put, let's start here. Let's do chronic cluster. There we go. Chronic cluster headache. Anything else? We did a lot tonight, guys. And you know what? Thank you for saying let's do some of these cases and look at them versus going and looking at the codes like we do when we take a case and we want to, we code it from scratch and abstract and stuff. We do that a lot with the risk adjustment group, and but being, really looking at how we're going to be doing it for testing purposes. It's a different way of looking at it, and we'll shake it up. Of course, I really love talking about the disease process as you may have noticed. And here, I believe in the next week or two, we'll start doing some live recordings. We got to coordinate with Boyd again. I just touched him the other day and to talk about, you know, getting some timing out for do that. We may do those on Mondays and doing them live or pre-recorded. I don't know, but specifically talking about A&P and the disease process, because the more you know that, the easier it is to code both for testing and for real world, because the guidelines make sense, you know, and so that's real important. You want the guidelines to make sense, then, you know the disease process. And but we'll do any special requests that come in. And again, don't forget that these are live, interactive, and, you know, just have your mics so that you can shout things out if you need to or ask questions. And I will still promise to follow up on the, let's see, a cabbage that was done, a repeat cabbage on a person with no angina, I think is what that was. I've got the note written down and I'll double check. I just want to check with Chandra because she's done a lot more auditing than I have, and that we had some codes that we were, you know, debating on, and so I want to get her input before I tell you what I think. And usually we always agree, but she has some, you know, she's got some insight and some things that that I don't, and she's really good at looking up resources. And so I want to be able to give you resources to just say, no, it's this because I say it is, and everything. So we'll give you a really good answer on that. Maybe she'll do it even next week if I give her a shout out to add to her ICD-10 and risk adjustment, because it was all about ICD-10. Any last things that we want to talk about? We are at 7:30 Central Time, 8:30 Eastern. So we are good to go, guys. That's it. So let me hit that last slide because I made this purposely and I think it's so cute. Go forth and code. Conquer the coding world. See you guys in the hub, the support hubs, or see you if I'm your coach. I'm sure we'll be chatting, and or see you in a week and a half. Bye, guys.